In 2016, ECDC reported 30,000 new HIV diagnoses in the European Union and the European Economic Area. What has also been shown is that during the past decade, this epidemic has more or less stabilized. Understandably, there are local differences that in some countries it still goes up a little, other countries show a decline, but overall there's a stabilizing trend. That also shows that the traditional measures that we use for preventing HIV, such as the use of a condom and behavior change, are not enough to curb the epidemic. So if that was all, then after a minute I could have stopped and told you the future of the epidemic is 30,000 new diagnoses. But fortunately, things have changed. Two novel, very highly efficacious prevention strategies have become available during the past decade. And very briefly, these two prevention strategies are: first, treatment as prevention. Somebody who is virologically suppressed due to antiretroviral treatment cannot transmit HIV to somebody else. This actually suggests that just try to treat as many people as possible and you can end the epidemic. Another method is pre-exposure prophylaxis with the antiretroviral drugs tenofovir and anthracycline. It has been shown in various randomized controlled trials that individuals that take PrEP, high-risk MSM notably, that take PrEP have an 85% lower risk as compared to high-risk MSM that did not take PrEP. And these two studies have led to a widespread optimism in the international community that we can use this to end the epidemic. And the most vocal proponent of this ending the epidemic hypothesis is the World Health Organization that defined the 2030 goals and incorporated them in these goals. So the World Health Organization declared that prevention strategies can end the epidemic in 2030, meaning that in the year 2030 there will be no new HIV diagnoses across the world, suggesting that somewhere at the start of the 22nd century, when the last HIV-infected individual that is virologically suppressed, when that person is buried, that at the same time we bury HIV, and HIV is something for history books. That would be perfect. The aim of my talk is, can Europe reach these goals, and at what cost? So the contents of my talk, I will first very briefly go over the real-world evidence of the novel prevention strategies. That is important because all the prevention strategies have been shown in randomized controlled trials that have been performed under very well-controlled conditions that cannot always be met in real-world life. So what do we know from real-world evidence? And the second, and that is the largest part, is we're going to talk about mathematics. Don't worry, I will not show you any equations. I will talk to you about modeling, how that was used to make predictions about the future in the coming decade. Given the fact that costs are so important, I'm also going to talk about cost effectiveness. So let's start with the evidence for the novel prevention strategies in real-world settings. Now, the novel prevention strategies are highly efficacious. We know that from the trials. But what it has a major problem is that the effectiveness that is measured in real-world settings can be lower. For instance, treatment as prevention will only work if people become identified or become diagnosed immediately after diagnosis. And we all know that a lot of patients are still diagnosed relatively late and therefore have a detectable viral load and can continue to transmit the virus to others. And these late diagnoses are a problem in daily practice. ECDC has estimated that about 50% of patients across Europe are diagnosed late, defined as a CD4 diagnosis of less than 350. In the Netherlands, the country where I come from, the highest risk group are MSM. We have free HIV testing is available for these men. And despite of that, and we previously spoke about stigma. Stigma against MSM in the western part of the Netherlands, where most people live, is almost zero. It's negligible. Despite of that, we still have 37% late diagnosis and 20% of MSM are still diagnosed in the AIDS stage. So the real-world evidence for this case that treatment as prevention may work in a real-world setting comes from London. It comes from a study that showed and compared different sexual health clinics and showed that in those sexual health clinics where increased testing was offered, that in those settings the number of new diagnoses was reduced over time by 32%. So let's first have a look at those settings where testing was not expanded. On the left-hand side, you can see the number of tests. On the right-hand side, you can see the number of diagnoses. And in this analysis, they made a difference between people that were testing for the first time in the dashed line. Also in blue, the number that were diagnosed among new testers, and also the repeat testers. That's the solid line, and the orange-yellow is the number of new diagnoses there. And you can see that the number of tests, the lines, remains fairly equal over time. Those were 30 health clinics. Then if you go to 5 sexual health clinics where testing went up. Again, the same colors for the repeat and the new testers. Left-hand side are the number of tests. And you could see that especially in the repeat testers, the number of tests almost doubled in a 3-year period. So it showed that testing went up in these areas. Now, if you combine that in the number of new diagnoses over time, so the left-hand side, you can see the number of new diagnoses, and then the solid line is the 5 clinics where testing went up, and what you can see is that somewhere in 2015, the lines gradually started to go down, whereas the dashed orange-yellow line, where the testing remained the same, the number of diagnoses remained fairly equal. So this is an ecological study. Actually, that indicates that there is no direct effect. For instance, if in those MSM who attended that clinic, those clinics where the new diagnosis went down, all of a sudden they decided to use condoms the whole time, then also the number of new diagnoses would go down. But that's rather unlikely. In the paper, the authors of this paper also address the availability of PrEP, and they conclude that PrEP was available, but that could not explain this decline. So this is real-world evidence that if you test more people so that you can place them more quickly on treatment, then that will have an impact on your population-level HIV diagnosis. PrEP in the real world was something that was shown to work by data from Kaiser Permanente. Kaiser Permanente is a big healthcare insurance in the San Francisco area. And in the year 2014, PrEP became available already in 2012 in the United States. They had 657 individuals that started PrEP. These were high-risk individuals, as indicated by the fact that almost 1 out of 3 within a year had an STI, but there were no new HIV infections in this group. So there is some evidence that this is working also in a real-world setting. Now let's move on, and let's have a look at the future HIV epidemic. What I would like to emphasize is that prevention, because that is important now, given the fact that we have such a powerful tools that we can roll out, is that prevention always goes hand in hand with economic costs. Costs are really a key element of HIV prevention. And the reason for that is, who should we test more frequently? We could go out today in Rome and try to test as many people as we can, but then it's very likely that we test people that have a very low risk or no risk at all of getting an HIV infection. But you spend money on that testing, and that is money that you cannot spend on something else, like organizing a new election. A problem for PrEP is what has been shown in a study by Susan Bookbinder, and she used the data from the IPREX study, which was the first randomized controlled trial showing the efficacy of PrEP, is that the number needed to treat of PrEP could be as high as 62. The number needed to treat means that you need to treat 62 individuals in order to avoid 1 infection. But that means that you have to also spend cost on 61 individuals that would not have been infected. So this was the overall risk. It was shown also in a sub-analysis that individuals that have a higher risk, and the number needed to treat goes down, but it never gets below 10. So costs are very important. So the main question in studies like this is, which prevention strategies prevents most infections at the lowest cost? I have to emphasize that doing studies on this, so on the economic impact, but also in the epidemiological impact of prevention, that this is something that is very complex. Because you do not only have prevention on an individual level. For instance, a person that takes PrEP has an 85% reduction of getting infected with HIV. But so does his or her sexual partners. For instance, if HIV is prevented in somebody who is taking PrEP, who would have been infected otherwise, and if that person would have infected 2 other individuals, then without PrEP, these 2 other individuals could also have infected 2 other individuals, and again 2 other individuals. So it's like a snowball going through a population. So this one single PrEP user could actually, in a population level, avert far more infections. And in order to identify and incorporate both this individual level impact or this population level impact, we need a transmission model. And that is where math comes in. But I promise you that I will not include equations. So I'm going to take the overall structure and discuss that with you. And this is an overall structure that is used in actually all the mathematical models that are out there. What you always start with is you start with individuals that are not infected. Then upon infection, they first go and progress into the acute stage, which is brief but highly infectious. And then after 10 to 16 weeks, they progress into the chronic stage. And in mathematical models, we always make a distinction between different CD4 cell counts. So greater than 500, between 350 and 500, and between 200 and 350. And the reason why this is done is because this enables mathematical models to take late diagnoses as are happening and occurring into account in daily practice. So you could calibrate your model to that. And then finally, if people are not diagnosed yet, they progress into the AIDS stage. And unfortunately, we all know that still, even in Europe where treatment is available, people are still diagnosed with AIDS. Fortunately, we have treatment. So people go to treatment and they're not really infectious anymore. They may have virological failure, but people that are virologically suppressed do not transmit the virus. Now, what you do in such a model is you make the model in such a way that you can calibrate it to a historic epidemic in the population that you test. And the historic epidemic, you calibrate it so that you have the same number of new and existing diagnosed individuals and the proportion diagnosed at a particular CD4 threshold. And if you do that, then you reconstructed a historic epidemic, and then you can evaluate what happens if you, for instance, increase testing or you introduce PrEP. You can add to all these boxes, you can add costs. The way that, or the mathematics behind that, the way that it works is as follows. Suppose that somebody, this is a model for Rome. Let's suppose that this is a model for Rome, and there is a new MSM. And that MSM tonight has somewhere in a gay bar meets this very handsome Roman guy, and they have sex, and that person does not have HIV. Then what is actually happening in a model like that is you make a probability. So you calculate the probability for transmission. That is based on the probability that that person is in the acute stage. And that is actually the number of people in the acute stage in Rome divided by the total Roman population times a transmission probability, which is quite high. You do that also for the chronic stage, for the AIDS stage, etc. And then based on that, you can come up with probabilities, and that is how a mathematical model works. Effectiveness in a mathematical model is usually, or excuse me, I'm going too fast. If you take PrEP into account, then what you can do is you can extend the model. So you have people that are on PrEP or not on PrEP. And this is dynamic. People can stop PrEP, people can start PrEP. And you assume that people that are on PrEP have a lower risk of about 85% of getting infected. Effectiveness in a cost-effectiveness study is always expressed in the same way, based on so-called quality of life years, quality-adjusted life years, and those range between 0 and 1. 0 means that somebody is dead. 1 means a life in perfect health. And the values for qualities that are used in HIV studies are given in this table. The first column shows you the quality or the status of the patient, and the second column the value. And these are based on several well-established papers that are out there, and they're actually always the same. So what we assume is that somebody who has a CD4 greater than 350 has a quality of 0.94, and this goes down to 0.7 if somebody has AIDS. Treatment nowadays is fairly non-toxic, so we assume that that is the same as somebody who is in the chronic stage and has a very high CD4 cell count. We always assume that somebody on PrEP has a perfect health. So you take that into account, and then you start making your calculations, and you add that up over a period of time. The way that cost effectiveness is then calculated, and let's suppose to do that for a situation where PrEP is available, then what you do is you calculate a scenario where PrEP is available, and you assume probably that is going to generate more cost. And then you subtract the situation where PrEP was not available, and you divide that by the gain in qualities due to PrEP. And your gain in qualities could come due to averted infections, meaning that people spend time in perfect health for a longer period of time. Something that is always done in economic analysis like this is that discounting is taken into account. And usually that's 3%. That means each year you discount by 3%, meaning the cost that you accumulate in the first year and the second year are 0.97 times the cost in the first year. And in the third year, it's 0.97 times the cost in the second year, etc. The reason why discounting is taken into account is to give a bigger weight to the cost that we make in the short run is compared to the cost that we make in the long run. Because the decision to fund something is taken right now, but the benefits only pay back in the later stage. What is always done in HIV research is, we all know that HIV is usually first time diagnosed in people that are still in the primes of their lives, that are relatively young. In the Netherlands and in Germany, where I did most research, MSM that are diagnosed have a median age of 35 years. They could easily still live for another 45 years. So the benefits of PrEP should actually be accounted over this time that they are still alive. So what we always did is we did a little of a conservative thing, and we thought that should be 40 years. 75 years, the average person in both Germany and in the Netherlands, the average male dies at an age of 80 to 85. So this is conservative in that respect. The cost-effectiveness ratio in various analyses is always based on a so-called willingness to pay ratio. Lots of countries do not have a threshold. So generally what you do is if it's less than 20,000 euros per quality-adjusted life years, then we call it cost-effective. The United Kingdom uses less than 30,000 30,000 pounds per quality. They're not using euro, of course. Let's have a look at some studies that are out there. On testing, there's a lot available in Africa, but not really in Europe. There's a paper by Rebecca Bagley that was published last year in Lancet HIV. And what Rebecca Bagley and colleagues did is they went to a borough in London, that is Hackney, that is just above the Thames, as you can see on the map, so a little in the northern part, that is characterized by a relatively high prevalence for English standards of HIV. It was above 0.2%. And they introduced, or what they did is they increased the number of testing in a model by 4-fold by GPs at a price of 25 pounds. And they found that over 40 years, this was cost effective as a ratio of 22,000 pounds per quality. So this is cost effective. Now let's have a look at PrEP. And in PrEP, it's completely different. PrEP, the price of PrEP has changed dramatically during the past year. PrEP until this summer was only available as a branded version. And what we found both in the Netherlands and in Germany, when that patent expired and generic versions became down, actually the price skydived. It went down like crazy, by 80–90%. And both in Germany and the Netherlands, the price of PrEP now, generic PrEP, is 50 euros per month. Add to that, there should also be other costs that should be added. If you have some water for me, please. So the cost of getting a kidney function and HIV testing. the cost of treatment probably remain very high in the future. Currently, the cost of treatment, thank you. Currently, the cost of treatment in the Netherlands are about 13,000 euros a year. And in Germany, I found everything is more expensive in Germany. It's 17,000 euros a year. So this is a paper that we published in Lancet Infectious Disease, where we had a look at the cost effectiveness and the epidemiological impact of PrEP. And what you can see here on the left-hand side, on the axis on the left hand, is the number of cumulative infections that we avert in the short term after introduction of PrEP. And this is a 2-year period of scaling up PrEP and a 10-year period to really study the long-term effect. And the year is on the horizontal axis. Now, depending on the PrEP effectiveness, I mentioned in the beginning that the efficacy of PrEP in randomized controlled trials is 85%. But in real-world practice, it could be different. So we ranged that over a big scenario, and we found that it will avert about 1,500 to 2,500 infections if we target 10% of the high-risk MSM. And that is about 12% of our infection. So it's a reduction of 12%. What we found is that, what we also did is that we started treatment immediately upon diagnosis, but we also found that there is no elimination in 2030. We then had an impact on the budget impact. When we published this paper, PrEP was not generically available. So we had big discussions what the price would be. So what we therefore did is we didn't know. So we ranged the price by steps of 10%. And finally, now the price in the Netherlands of PrEP is 80% lower. And as you can see, in the bottom, the red bar is that PrEP, in that case, within 40 years, is cost-saving to the Dutch society. And based on this paper, the Health Council, which is a Dutch advisory organ to our government and to our parliament, advised our minister to reimburse PrEP. And we are still waiting for his decision. I also repeated this analysis for Germany. So based on this analysis, I was invited to repeat that for Germany, and we found the same thing. Something that we did in Germany is we also wanted to have a look at when is it cost saving? So after which period of time? And that is given here. So when are the cumulative costs of a PrEP introduction lower than the cost that you would have, or actually the cost that you are saving simply because you do not have to treat people anymore? On the left-hand side, you can see the cumulative costs, and on the axis, you can see the number of years. And where, at the right-hand side, where you can see that the lines are crossing, the bar is the break-even point. And you can see that that break-even point is reached between 9 and 15 years. So within 15 years, German society starts to gain money. Now, you do have to know, and you all know, that tenofovir and emtricitabine are also popular in first-line regimens. And TDF is generically available. So why not give TDF and FTC in a first-line regimen in a generic version, and you could also save costs like that? I do not believe that an 80% price reduction, as we have seen in the Netherlands for generic PrEP, is likely to occur in the near future, because treatment has always consisted of 3 different drugs until now. And the third drug that we give, the most popular of that one is dolutegravir, and that's not going to expire within 10 years. And also we have TEF. So I think that the prices remain same. But we repeated the analysis where we simply do not know what the price is. And let's see what the cumulative costs in Germany are after 10 years after PrEP introduction. What you can see on the left-hand axis is the price reduction of ART. And on the horizontal axis, you can see the effectiveness of PrEP. What you can see is that PrEP will be cost-saving if it's highly effective within 10 years and if there is a modest price reduction. Generally speaking, within 10 years, PrEP is going to cost German society money. Then the break-even point and the time of years when we are going to reach that. Again, on the left-hand side, you can see the price of ART, the future price of ART, and the reduction of that. The effectiveness is on the upper row. What we found is that the break-even point, if it's green, it's reached within 15 years. And that is generally reached for a very high efficacy or effectiveness of PrEP in real-world settings, or when the difference between the current price of ART, which is very high, And the future price of ART, when it's generically or when there's price reductions, is small. Then within 15 years, German society starts making money. Nonetheless, in all other cases, within 25 years in general, PrEP is cost saving, except these two little fellows down at the left-hand side. So elimination in 2030, I checked the models that were published, and I also checked the models that we made for the Netherlands and for Germany. And actually, even if you increase the proportion of MSM on PrEP to 50% of your high-risk MSM, if you expand testing, then still complete elimination in the year 2030 is actually very unlikely. And then I didn't know about the first speaker and the talk of the first speaker when I was making these slides, but given that the fact that Central Europe and Eastern Europe, it's not very likely that it's going to be hit over there in 2030, or this elimination is going to be reached over there as well. So this brings me to my conclusions. So we have the tools to eliminate the epidemic by 2030. But this requires frequent testing of people at risk. And this costs money, as has been shown by Rebecca Bagley and colleagues in London. And this was actually in a place where the prevalence of HIV was relatively high. So this doesn't mean in like a small village somewhere in the Netherlands, it's probably going to be more costly. Furthermore, if you give PrEP to people at high risk, then it is going to be cost saving. Some study that I did not mention, but it is very important, is a study by Valentina Cambiano and colleagues from a university and college in London. Earlier this year, in Lancet Infectious Diseases, she showed that PrEP, when used on demand, is also cost-saving in the United Kingdom. So prevention strategies in isolation are unlikely to end the HIV epidemic. And PrEP should always be introduced alongside expanded HIV testing. So you may decide not only to introduce PrEP, but also to expand HIV testing to the general population. But it is unknown if this is going to end the epidemic. So novel prevention strategies can strongly reduce the epidemic. Elimination in 2030 is unlikely. And what we should actually say that based on the analysis we did in the Netherlands and in Germany, and analysis that are always also available in the United Kingdom, is that if you invest money now, you can save money for future generations. But these future generations, the decision about spending that money have to be made by politicians. And politicians think in terms of 4 years. Now, I do know that and it's actually 15 years before you're going to take that money or save that money in Germany. I do know that Angela Merkel is in power for very long, but I do not think that she will be there for another 15 years. Who knows? Finally, I did not do all this work alone, and I would like to thank my colleagues in Rotterdam. Special thanks go to Brooke Nichols, who did a lot of the coding for the Dutch model, and my colleagues in Germany. And the German part of this study was funded by DACNA. Thank you very much.